Okay, so I want to talk a little bit about the opportunity that organizations have these days, because lately what's come out is that there is money available for long-term care to be able to access funds from the Ministry of Long-Term Care to be able to backfill, essentially to backfill and provide opportunities for nurses in their organizations to take programs through, particularly through Wounds Canada, which is great, to be able to become wound care champions in the organizations. Wonderful.
In Ontario. I'll just say for anyone watching, listening in Ontario.
Yeah, right. So this is terrific. I have no sort of issues about being able to. I mean, it's great that the ministry and the government in Ontario is actually looking at wound care, which is something near and dear to my heart. This is a challenge in patient care across the board, but particularly when you're looking at people who are seniors in particular with chronic conditions like diabetes, congestive heart failure, vascular issues, nutrition, dementia, et cetera, et cetera. So this is something, it's an opportunity for long-term care facilities to do this. However, I think one of the things that needs to be addressed is you have nurses and RNs, so registered nurses or practical nurses, PSWs, so personal service workers, who are in day-to-day contact with patients, with residents in long-term care, and are at the forefront and able to actually help to prevent skin breakdown, but also deal with whatever is, kind of there, the garden variety wounds. So if you're only training specialized people, you're going to end up with the same kind of issue that we have in the healthcare system in general, which is, we've specialized to such an extent that a generalist feels either they can't do something or they don't feel they have the knowledge to be able to do whatever it is that needs to be done that is pretty basic. Like
Mhm.
wound care is not it's not rocket science. it's it's pretty honestly, it's pretty easy to be able to identify what needs to be done if you have basic training, basic education. The issue that happens is that the basic training and education, scope of practice of nurses in Ontario is, clearly wound care is within their kind of wheelhouse. The issue is that they don't learn this in their education programs. And it's not because of the sort of inability or the unwillingness of faculties or schools of nursing um, at the university or college level to do this. The problem is they just don't have time. I've talked to lots of uh, deans and chairs of departments and faculty, and they've
I'm
all
familiar
said,
with the same.
yeah,
Yep, I've heard the same issue in the schools of nursing that I've worked with. Exactly.
yeah,
There's just not enough room in the curriculum.
yeah. And if you can't put it into the curriculum,
Yeah.
then how do you do this? And, this is where I started 20 years ago saying, okay, fine. If you can't, if we can't do this within our program, we still need to do it because
Right.
nursing students come out as nurses and are immediately put into positions where they have to respond, they have to do
I
stuff.
I agree. I've heard the same thing from schools of nursing, is that they really, really, really would feel it is of high value and must be added in some way for current students or recent grads to pick up that knowledge. And because they will be tossed into, and their research, with the hospitals around them shows that these nurses are immediately tossed into situations where they need those skills.
And when you look at at retention,
Mm.
this is one of the places where it's not really talked about a lot, but if you consider why do nurses leave nursing, a lot of it is because they feel overwhelmed with what they're expected to be able to do, and they just don't have the skill set to enable them to competently or confidently do that kind of, in
Yeah.
my view, pretty simple work. Like honestly, like I said, wound care, it's not, it's not rocket science. So it's a skill that is kind of like learning how to drive a car. If you learn
Mhm.
how to drive a car, you can drive any kind of car pretty much, except, maybe something really exotic. But these are basic kinds of skills. So I think, like I said, I think it's really great that the Ministry of Long-Term Care is providing funding for these big program options of developing champions. Wonderful. I think having champions, but the having worked in that area for many years, my observation would be when those specialists are not there, what happens? The nurses are again saying, well, I have to wait for the champion to come in to see this patient. When in reality, if they have just the basic training, they can at least identify when that champion should be involved. So my, the programs that we offer through Chen are designed to be that kind of first step. Learn the basics within a short period of time with expert clinicians, with sample products that you can play with, because nurses are kinetic learners. They, like to have something in front of them that they can sort of touch and feel and do themselves. And we do that. And they can do it, this is online, right? It's live online.
Yeah.
So my suggestion is to really, sorry to keep going on this, but my thinking is great, let's do both. Yeah.
I hear you say, and I totally agree. This is from just the perspective I take, it's on this workforce development space. Number one, you have a nursing scope of practice. So why not expand the education that's needed for nurses to practice within their full scope? And wound care is solidly in their scope. So they need it. And why? Now, what is the benefit of this to any organization? You'll have a workforce then that is functioning to the full extent that it can, to the full extent of the responsibilities that you can give them. And actually, you probably do give them, but they can do it with and decrease the risk and increase the benefit for better health outcomes, right? So isn't that the beauty? That's what you want in your workforce, is that they're functioning to their full capacity.
Well, and it keeps
And
them there.
it
It
does,
keeps
and
them
it keeps them
engaged.
there.
Like,
It keeps them there. And
yeah.
these are ways that, from a organization or a staffing perspective, from the perspective of the CEO, you are using your workforce to its full extent, and also you are extending the capacity of the services you provide as a result.
Right.
So, how will that help, get people healthier faster, or get them through the ER faster, or get them through clinics faster, or if you're at the community level, get health care to them in a more immediate and responsive way than them sitting on waiting lists. Use your workforce wisely, is all I can say. I think it
Mhm.
comes down to that. Use your workforce wisely and make sure that they have the education they need to really reach deeply into the full scope of their practice and do what they need to do.
Yeah. Yeah.
Instead of leaving a lot of capacity on the table.
Well, and when you talk about, if this was, if these were businesses, when you look at return on investment,
Hmm.
right? Like the ROI is something that everybody looks at in business, right? Like you
Oh
look at
yeah, it's a
if
standard
we've got
measure.
all these people in here, then
Mm.
what are they doing with
Yeah.
their work? And if you've got situations where you have patients or you have residents who develop skin breakdown or who have skin breakdown, and we're putting a dressing on, we've been putting the same dressing on for 3 months. I mean, if I talk to when I talk to patients and say to them, so how long have you had this leg ulcer? And they say, oh, 18 months. And I'm like, what? These should be closed within maximum 12 weeks, like maximum 12 weeks. And so people are walking around or lying around or sitting around with these wounds that just because we're not doing what needs to be done in terms of best practice, mainly because people don't know what to do, and it goes all down the line in terms of physicians don't learn this in their education programs, nurses don't learn this in their education programs. So if you're not learning these skills, these pretty basic skills, then how are you supposed to be able to deliver best practice, or evidence informed practice when you just don't have the knowledge to be able to do that? You're doing sort of, well, this is what I learned to do when I was in school 15 years ago. Well, it's not the same anymore. So I mean, I'm digressing a little bit, but in terms of the return on investment, if you start to consider the sort of really pretty minimal investment in knowledge transfer in a situation where you provide programs to people like we do at Chen, where it's kind of like a concentrated burst of learning.
Mm.
But it's a burst of learning that is engaging, as opposed to, you can say, well, we can offer asynchronous learning. We can offer people, they can do it on their own time. They can sort of go to the computer and move all these things around and play with all these things and, have this sort of self-directed learning. But at the end of the day, the return on investment is they don't retain it. People don't retain that kind of knowledge, and the research literature is out there that would that supports that. That it's not something that people in the long term will retain, because one of the benefits of the kind of program that we offer, aside from the fact that it's with, somebody, a clinician who's right there having the conversation, or, it part of the teaching process. But the other thing is the networking that goes on in the class. So our courses are small, we have small groups, and they have opportunities then to kind of feed off each other and learn from each other as well. So, I think that that's a kind of win-win. And then, yes, certainly have those champions in your programs, but recognize that you need to be educating the bedside nurse PSW at the same time. When I worked in the hospital as an acute care nurse practitioner and my focus specialty was wound care, I always took the nurses with me when, I get referrals to see a patient, but I would always say to the nurse who was looking after the patient that day, come with me. We will do this together, because I'm just coming in as sort of, the specialist. You're the one who's actually looking after this person on a regular, for the full shift. So to me, that's what's really important. We have to get everybody on board, not just sort of keep it at a specialist level that takes months to actually
Yeah.
learn.
Yeah. Yeah. No, and I completely understand the value and importance of the specialist. Um, but I do feel it's an incomplete framework for the necessities of clinical care in, for example, long-term care. I'll use long-term care as an example. Um, because you're leaving a lot of resources on the table because, as you said, what if that person's not there? And this is human care. This is care of a human living body. And these bodies don't function just 9 to 5. They're 24/7. So what happens at midnight?
Yeah.
And you've got to do something and it's midnight. So I'm going to go to, I'm going to use the example of clinical leadership.
Okay.
And the expectation of at the bedside, everybody is a clinical leader. It's not, doesn't mean you have leadership doesn't in this situation, it's not the CEO. It's leadership over the clinical care and the practice that you're doing in that moment. And you're doing everything but using your expertise to do what you need to do to care for that patient, but also taking leadership and advocating for them in an independent way within your scope of practice. Um, and I'm going to attach that to what you've, Rosemary, have said. And this is what I believed in for like, not believe, just believed in. This is best practice. When you're training people to act as clinical leaders and to expand the capacity of your workforce, you've got to do it in the way that they can actually then go back into that scope of practice and do what they need to do in the confusing, difficult situations they may find themselves in, where they have to stand independently and take leadership and responsibility for their decision making. So learning in a self-directed way is has been shown is not, and I've seen it for myself too, is not the best way to train those people to function, say as a wound care, a nurse delivering wound care at midnight on their own and needing to make clinical decisions on their own in a very complex situation. So I'm going to just refer back to something like the Lumina framework, where you will, and the necessity of live interactive learning to learn complexity and decision making within complexity, because you're functioning at a very high capacity within a professional practice where you're making decisions independently and you're taking responsibility to those decisions against risk factors.
Hmm.
So
Right.
you're drawing on your own expertise, and in order to and balancing risk factors, and in order to do that, you need to have been trained not in a um, task list kind of way. This is what I do when, and it's always the same and perfect because humans are not machines, and
Right.
their bodies don't fit on the task list
Hmm.
or, the decision tree. So you need to be able to work with outside of that decision tree because it's
Yeah.
complex.
Yeah.
So you're working at a very high professional capacity level in taking responsibility for your own decisions and standing by them.
Hmm.
So that needs coaching, mentoring, interactive learning where you can ask questions and understand how to function comfortably within a world where the next step that happens can't be predicted. So you have
Yeah.
to learn to
Well, yes,
anticipate
yes,
that.
and
Yeah.
I mean,
And
just thinking about wound care. Yeah.
yeah, you're not necessarily going to know what's going to happen next. It's not predictable. So that's when you need that experienced coach, mentor, say in nursing, nurse who can lead you through how to use your knowledge and skill to make the decisions that are necessary and to provide the care that are necessary.
But at a level, but again, sort of going back to this whole thing about
Mhm.
specialist versus generalist, right? And to me, when we look at nursing, a nurse is somebody who has taken a 4-year university program
Mhm.
or a 3 year or a two. And now what it is usually it's like you can do, 2 years at community college and then 2 years at university or whatever, the way it's configured. But the point is that this is not coming out of grade 12 and going to
Mhm.
work. Like this is beyond to me, this is beyond the sort of training level. This is something where if you have a degree, professional degree, then you should have this knowledge base to be able to practice with something that is essentially a very straightforward physiological issue when skin breaks down. Like
Mhm.
I'm talking
Yes.
specifically about wound care. And it's when there are, so like when I worked at the hospital, at a certain point, the nurses that I worked with were confident with their skill levels with basic wound care. And when the medical teams would come around and say, oh, we should get the specialist to come in and look at get her to
Mhm.
come in and see this, the nurses would say, well, actually, no, we're okay with this because they could manage the sort of straightforward wound care because they had spent all that time with me already processing, learning exactly what we're talking about, doing that kind of processing thinking. And it's all about critical thinking.
Okay, then can I ask you a question? Maybe I've got this all wrong. I don't know. If nurses learn in a preceptor environment and their competency is assessed, say through an OSCE framework, why postgraduate, professional learning, why is professional learning for nurses to some extent, like wound care, being instructed in an on-demand, self-directed way? When they originally trained, that's not how they were trained. The training was practical, applied, um, 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 based in coaching and using coaching and mentoring from more
Yeah.
experienced
That's
nurses,
a really good, that's a really
right?
good point because when you think about, I mean, I think about training, I think about that's what I do with my dog.
Yes.
Like it's this sort of when you're looking at information, you
Hmm.
can do autonomous learning or asynchronous learning if it's information kind of learning that you're
Hmm.
doing. Like I need to know, I don't know, in terms of some of the pharmacology stuff is like
Hmm.
it's information, but when you're looking at something where you have to have that ability to assess and make decisions about what to do, then yeah, you really need to have that kind of preceptorship. You're right,
Yeah.
and we get back to the whole thing. I mean, we get back to the whole thing of the, the education system doesn't work. And it it doesn't, so this is a whole other conversation, but
Isn't it?
oh my God. But
Kettle of worms.
yeah, yeah, oh, forever. But the
Yeah.
thing about it too is that, when you start to consider the current, yeah, when you start to consider the current healthcare environment, I mean, I talk about this and write about this all the time, that, the current healthcare environment is one that is very different from the environment even 5 years ago. Pre-COVID,
Yeah.
look back to sort of where we were at then and
Mhm.
our kind of sort of rosy world view,
Right.
to where we're at today, which is, I mean, I from, in terms of the technology, the access to technology, the AI ability capabilities that we're beginning to explore, and I'm positive about that. I think this is a good thing. But I think that we are still entrenched in an old mechanistic way of thinking that doesn't, it's like we're still in the cave or in the box, and we're kind of bouncing off the walls because we haven't
Mhm.
realized that in actual fact what we need to be doing is reconfiguring this whole thing. Like nursing education, medical education, we need to begin to address a lot of these underlying issues that are bubbling to the surface now that we never really, culture, diversity, equity, all of those kinds of things that never seem to really, have much impact on how healthcare was delivered is something that we need to begin to look at. The same way we need to begin to look at the concept of patient-centered care, which
Mhm.
is so totally not there. You know, you talk to anybody. I mean, you talk to healthcare professionals, you talk to patients, you talk to families,
It's not that.
everyone
It's
agrees.
marketing. It's a marketing. I'm sorry. That was a marketing scheme, in terms. It really was.
Yeah.
It really was. Come on, like I mean, on the ground, will never say healthcare providers don't want to provide patient-centered care. Really, they do. They're
Mhm.
fighting within a system that doesn't support it. And the term patient-centered care is just, I don't know, some bureaucrat's office invented it to make the voters happy. But how can
And
it,
to make it look good.
yeah,
Well, and when
exactly.
I think about some of the other kind of, I remember when, the Six Sigma, and I have a daughter who's an engineer, right? Who really
Yeah.
likes this stuff. Well, it's
Lean,
great
yeah,
when you're talking about widgets.
yeah.
As soon as you put the human equation in there, it
Mm.
goes totally off the map.
You know what? I was horrified. Back in, oh my goodness, like 15 12 to 15 years ago, I remember hearing about people talking about Lean Six Sigma and healthcare. And I was horrified, and I still am,
Mhm.
because our bodies are not machines. They don't function. Each one is not identical. You
Yeah,
know?
well, and the systems don't work too.
Exactly. So Lean
Yeah.
Six Sigma, maybe it can apply to the data systems and
Yeah.
the infrastructure, like literal building, the mechanics of a building that houses healthcare, but it can't apply, and I think everyone agrees with me, 'cause it's just common sense. It can't apply to a body, to a living
But it
human
can
being.
apply, but it can apply to things like, for example, dressing supplies.
There you go. Yes,
Like
yes.
if you're living in a place where,
Like a
the
supply
patient
chain.
compression, for example, on
Yeah.
their legs,
Mhm.
compression wraps, and you can't access compression wraps because you're living in some small community. One of the things that I
But I
think
would, I'm going to say, can I say this so I get it in this recording? Lean Six Sigma cannot even apply to patient flow.
not patient flow,
Because
no,
people are
no.
people, they're human beings and human
Yeah.
bodies, and you cannot treat patients, say in an ER, as if they are on a cattle train, just get through the gates. Don't care what's wrong, just get through the gates. I have to get you through the gate.
Well, even the
Not the
concept
way
of
it can work for
triage,
them.
even the concept of triage,
Yeah.
I'd like to know who designed the triage framework.
Yeah.
Is
Did.
what? Because it doesn't work.
Question. Yeah.
It doesn't work. I mean,
Yeah.
people are multidimensional in terms of
Yeah.
their issues. I mean, it's the same thing when you go to see a healthcare professional who says to you, I can only deal with one issue.
Yeah.
Well, unfortunately, my body and my brain, we don't work that way. Like
Yeah.
we have sort of more than one thing, generally speaking, going on at the same time.
Yeah.
So, so there's that. The other part of it,
Agreed. And I've had a doctor actually stop my medical appointment because she said, I only do one issue at a time. And I said to her, but they're connected. So I think they're connected. So can you help
but
me out?
part of the, but
Anyway,
I understand, but you see, but I understand also that part of the issue is the way, I mean, this gets back to sort of our, the kind of macro, meso micro systems, you know, and how this kind of all fits together or doesn't fit together. And I think a big part of what happens too is that in the healthcare system that we currently operate within,
Mhm.
the role of the physician, despite the fact that we talk about teams, they are still a gatekeeper position. So physicians are still in a gatekeeper role. And the big problem for them is that on top of being the gatekeeper, you know, the other issue is that they have to get paid.
Yes.
And the payment system that we have is archaic. You know, that's a whole other kind of kettle of fish. But to me, I've always said like physicians, everybody else is on a salary in
Mm.
healthcare. Like, look around, you know, everybody's on a salary. So what dentists aren't. So, but you know, whatever. But physicians should be salaried so that there is work-life balance for one thing for
Yeah.
them, and that we can then get rid of the Ontario OHIP. We could, in theory, pretty well get rid of it. And how much money does OHIP cost Ontario taxpayers?
Mhm.
You know, who knows? I don't know. It's not something that is sort of out there in the public domain, as far as I know.
You,
So, you know, when you think about providing physicians, and, you know, I come from a family with a bunch of physicians. When you think about that, it would make life so much easier
Mhm.
because then they could focus on what they're good at, which is really sussing out what the issues are. They want to do that. They don't want to be, you know, they're unhappy too. Like this is not a happy situation for people. To be working in an environment where they think they're going to be doing good and they're frustrated, you know, they're also frustrated with the limits that they have placed upon them.
yeah.
Um,
Can I comment then? And I
yeah,
know people, I know I'm going to say something and I think we're going to get jumped on, sure. But here we go.
yay.
Yeah. So if you look at the way physicians are paid from a business perspective, I'm a business person. So if I hire a consultant on contract to do X, they're just going to do X. But if Y turns up, they're going to say, if you want me to address Y, you have to pay me more.
Good
So
point.
if physicians are paid and they're paid piece by piece, they're
Mhm.
not, it's unlike a job as a salaried position, as you were saying, Rosemary. They are paid based on a role, and the role has responsibilities, and those responsibilities flex, right? Because
Yes.
it's always built into a job summary, 5% for other duties as assigned. Okay. So it can flex based on the needs of the organization. So you've got contractor or consultant X, inflexible. You've got salaried position, flexible. Which one's going to be better for every patient coming through the door who is a complex human being? So, from a business perspective, as a business person, I would say um, if I want real ROI from my physicians, I want to get them to do as much as I can. And I don't want to give them a choice because I'm paying them. So they're going to do what I need them to do for the money I'm paying them. And I'll pay them fairly. But that's not what's happening. And I don't know, I've observed that for years. The fact that you raised it now just my ire went up like 200% because I've seen it for years and years, the decades that I've been in healthcare. And I've really thought, what an asinine way to have started to pay our physicians. So there we go. I just said it. Everybody
So,
yell at me. I really don't care.
no, but good point because so I just looked up while you were talking. I
Yeah.
looked up payment for an OHIP payment for general, I said, you know, respiratory related assessment. Okay.
Mhm.
Because lots of that going on right now, right? So, a standard in office visit with a history and exam The OHIP schedule value typically is in the range of 70 to $90, depending on the exact, this is OHIP, right? Depending on the exact code and time spent, with variances by year and enhancements. So I guess if you order antibiotics, then maybe you get a little bit more money. But this is I've worked my entire career with physicians who have said things and great doctors, like
Me too.
wonderful.
Me too.
Yeah,
Wonderful diagnosticians, wonderful caring
yeah,
physicians.
but who have
Me too.
said themselves
Yeah.
that this drives them crazy because this isn't why, when you go to medical school, this is not the thing that people tell you is that
Yeah.
you're going to
Nickel
be
and dime
essentially
to death.
nickel and diming stuff and
Yeah.
thinking about which code do I use. And
Yeah.
that's why you have to have, secretarial support that's able to do all those coding and at the end of the day be able to send all that into OHIP. What
Mhm.
if you were paid a salary of, I don't know, a GP, family practice physician making $250,000 a year,
Yeah.
and pension benefits, vacation time,
Right. Right.
all. And I know now there are a lot more sort of blended,
Mhm.
thinking about blended options. But frankly, why are we even still in this sort of blended option issue? Why don't we just say, you know what, like let's just pay
Yeah.
you guys what
Pay
you're
them.
worth
Pay
and
them.
pay the specialists,
Yeah.
somebody who's like an expert, like a cardiology surgeon, a cardiac surgeon or a neurosurgeon, pay them
Mhm.
$500,000 a year. Like they're worth it. These and the GPs are
And
worth it
so,
too.
and the GPs, you know what? Rosemary makes such a good point because I'll tell you, I've worked for many decades with physicians, really superb people. And it's the system that's the problem.
Yeah.
It's
Well,
not
like
the,
I said,
it's not the
if they make the
physicians.
yeah,
I've worked with physicians who, superb diagnosticians and who pore over a patient's case file trying to figure out what's going on. And, they're going more hours than they're going to get paid, but they're doing it because they are really good at what they do and they have a responsibility, to provide their care that's within their, scope. So they do it. Yeah, and we need to stop treating them like plumbers. Not to say
and
plumbers, not to say plumbers are, that
plumbers
they
are
find
really
it,
important. Oh my God,
but
yeah.
plumbers do work, hourly on their pieces, and that works because they're working on mechanics, which is more predictable in how it will, probably more predictable on how it will um, uh, react to whatever you apply to it, whereas the
Yeah.
human body isn't.
But the other part of that too is that, getting back to kind of what we were talking about initially around, return on investment.
Mhm. Yeah.
I think that's the other side of what we need to be really looking at is that we have a system or systems that are not responsive to the current environment that we're living in. And unfortunately, when you look at the Canada Health Act, which is wonderful, but it can't be applied. It just can't be applied because the world, Canada is it's a very different place from a sort of simple, it's like Medicare, it was a great concept. It is a great concept. But it's something that we have to really seriously look at without the sort of lobby group perspective. Like when I'll tell you when in Ontario, when way back, way back, there was an opportunity. So the government said, okay, we'll have focus groups in communities to talk about better ways of offering healthcare. Uh, healthcare. So I was working at the hospital in London at the time. I went to one of these sessions that was offered in London. And everybody who was at this meeting was from different community groups. And there were only two people who were there from the hospital, me and somebody else. And the other thing was that it was chaired by someone who was had a particular political slant,
Mm,
and
mhm.
I think that so there was definitely an agenda, that was
Yeah.
there. And it also was clearly the loudest voices were the ones that had attention paid to them. So, for example,
Yeah.
long-term care really lucked out, like they lost out
Yeah.
because they weren't and the hospital too, because we were not really, and the way it was set up was, again, sort of thinking about things from the kind of this model that no longer works. We have to rethink the way we set up our healthcare, not just the delivery of healthcare, but the delivery of healthcare education.
Hmm.
And I believe that we need to start with high school and really get people into thinking about, careers that are going to be in healthcare, but you don't necessarily have to go to medical school for 500 years, or, nursing university, college or university for 4 years. Why do we not really give opportunities for people who have skills, but who may not necessarily be at that, level to actually do something that's going to be within the healthcare system and pay them effectively? Because that's the other part. Nurses also are not paid what they should be paid.
Hmm.
That definitely has not kept up. I mean, I don't think that nurses today are paid anywhere the level of expectation. And that's the problem, is the level of expectation of their skills doesn't actually match what they know.
So, and this has always fascinated me because I've developed jobs before, in my previous
Yeah,
life,
yeah.
lifetime. Um, so I know what goes into setting that salary range. And it always comes down to level of independent thinking and responsibility. So it's fascinated me that considering the amount of independent thinking and responsibility that a nurse has by virtue of the fact of their scope of practice as an RN, that they're not paid accordingly. It's fascinating to me and a travesty, honestly. Um, because it's really based on, and you know what? And I think where the catch is when human resources and organizations are developing them is the level of responsibility that they're thinking of is organizational decision making, by which a nurse has very little, right?
That's a really
Yeah.
interesting
And
point. Yeah.
that's where the nursing salaries get tripped up, is they don't match what organizational decision making do they have. So they're an employee, they don't have very much organizational decision making. So that's okay. Let's pay them 75 to 100,000, but no more. No, for their professional skill sets only. Um, which is crazy. It's just crazy because what they're doing, and I always look at this from a business perspective, is they are the front line of your value chain, right? If we're looking at
Yes.
this as a B2C relationship, they are in the front line of your value chain to your customer number one. So, and they're delivering your product. So, from a perspective of what does the customer think of my services and my product, they're right on the front line. So, their skills and competencies, your business to stay in business is relying on how good they are. So,
That's really interesting.
so
Yeah.
if you're thinking of, I'm selling a shoe, okay, I'm Nike and I'm selling a shoe. How much does that shoe cost? Usually depends on how much demand I can create in the marketplace to buy that shoe. And the more I can demand I can create, I'm charging two, $300, $400 for that shoe.
And
Because
my
that
retail
shoe,
workers and my retail
right,
workers make $15
right,
an hour.
an hour, right. But they're right up front selling that high price shoe. So if the shoe is expensive, like healthcare is expensive. The nurse is part of delivering that healthcare. In fact, they're at the forefront of delivering the true value proposition of every single hospital and healthcare provider in this country, period, endpoint, that uses nursing. So why are they paid not according to their value proposition, based on that where they sit in the value chain? I don't know. I don't know. And maybe I have this totally wrong and some marketing person can correct me.
Sure.
But in the end,
We're open to
they're
having that kind
they
of
are key.
discussion. Yeah.
And if they're part of selling the service, and if they were a salesperson, they'd be earning commission. They'd be doing really well because they're selling the service, making sure the product or whatever it is gets sold, and they're doing it well so people come back. So if they were a
Yeah.
salesperson, they'd
Yeah.
be getting paid commission, but they're not. They're not. They're so devalued. They're so devalued, and I think it is financial. It's because the healthcare system was not built to really have the money to pay for everything that they've got. So they just somehow along the line, financially, the bean counters determined what's the soft spot. Where's the soft spot? Where people are less likely to say, I want to be paid more.
Well,
Where
we
they
don't have
start
a system. Yeah. I mean,
nursing
part of that,
staff, because
yeah,
they
but
have
part of that also, I think is like I don't want to move into a system where we have like in the US where you have, hospitals vying for customers.
yeah.
Um,
Oh,
and
no, I agree. I
when I
agree.
went to the, when
I
I
didn't
went
mean
to
for that analogy to imply that.
yeah,
Not
no,
at all.
no. And when
Yeah.
I went to the Disney Institute
Oh, but
for
but I
healthcare.
yeah,
Yeah.
but we
Well,
should
all I
think,
was going to say was when I went to the Disney Institute for Healthcare, the thing that, we were the few Canadians who were at this thing.
yeah,
And that's one of the big differences. But I think one of the places where we've fallen down in Canada is that we say about healthcare is what we say is, well, you're going to come anyway. It doesn't matter how clean the floors are or how, like now in where I live, there's a big,
captive audience. Yep.
yeah, well, right
You've
now
nowhere
there's a
else to
big thing
go.
about, they're using an ambulance bay.
Yeah.
They've turned an ambulance bay into a sort of temporary
I saw that.
area. Yeah. And
Saw
I
that
mean,
in the news.
bathroom, there's, it's terrible.
Yeah.
But what are you supposed to do if you have
Yeah.
a stroke or a heart attack or diverticulitis or, or some other thing going on with you? Where are you supposed to go?
Mm,
There is no alternative. That's the only place. So we're kind of, again, they're saying, well, we can do whatever we want because, you're gonna, this is, you're between a rock and a hard place.
yeah.
So you're going to need to come here. But if we continue to devalue nurses in particular, and I looked at a typical salary or the range is in Ontario is $29 to $55 an hour. Like, I'm sorry, that's just not, gonna cut it. So why
Right.
would you go into nursing as a profession
Mm,
if that's and if you can't get full-time work? And you're working casual or maybe you want to work casual
yeah.
and there's no sort of opportunity for you to do that. So we're creating a system that devalues the very people that we really need to have working, and not just working, but need to know what it is that that we need to have them working to their scope of practice.
We do. We do.
Yeah. And we currently aren't doing that. But anyway, we're, you know, we can continue this conversation later.
To
The
be
next,
continued.
yeah, to be continued. Our next, naked truth of healthcare with
Yep.
Tanya and Rosemary. So
Hmm.
welcome. Join us anytime.
Come
Let us
back.
know what you think.
Come
Yeah,
back.
tell us what you think.
Comment. Comment, like, share, tell people about us, and yeah,
And check out our website. Check out our
yes,
courses.
check out our
That's what we're
courses in
there
our
for.
website.
Yeah.
Yep, links are in the description, and don't forget to like and share, please. And we'll see you next time. Bye, everybody.
Bye.